Thanks everyone for coming. We just want to start by introducing Mary and Willie from the Larrakia Nation to do our welcome to country.
Good morning, everyone. This morning we're here for Diabetes Across Lifecourse, North Australia Partnership 2024 Annual Education Symposium. My name is Mary Williams. I'm Larrakia Tiwi Aniwaja. I would like to acknowledge and pay my respects to my elders past, present and future generation of Larrakia Nation. I would also like to acknowledge and pay my respects to the elders past, present and future generation of many other First Nations and Torres Strait Islander people here today and across Australia. My grandmother, Eula Williams, also known as Eula Batcho, was born under a special birthing tree at Bullocky Point, which is where Darwin High School sits today. The Larrakia are traditional owners of Darwin and the surrounding regions, including Darwin Harbour, east to the Adelaide River and south to the Finnis River. We're the saltwater people, and traditionally our lives are dependent on the coast and seas. The Larrakia, also known as the Gulamarinjan or Dungalaba, after our main totem, the crocodile. We are one of the many other First Nations that are of the oldest living culture in the world, over 65,000 years old. Our connection to this land is ancient and profound, rooted in generations of stewardship and spiritual reverence. Garamilla is not merely a piece of land. It is our cultural heritage and traditional identity. Our ancestors have lived, hunted, and performed sacred ceremonies on this land for countless generations, leaving behind a rich tapestry of history and wisdom. Garamilla, our country, is a living landscape. The culture, the heritage, the laws are linked to this land. The seas, the beaches, the mangroves, the creeks and the rivers you see, it's me, my people, and my ancestors. The crocodiles, the fishes, and all the marine life you see, it's me, my people, and my ancestors. All the birds and all the animals you see, it's me, my people, and my ancestors. The hills, the escarpment, and the land we walk on here, it's me, my people, and my ancestors. When you come to our land, we welcome you to walk and be with us on our ancient land. On behalf of the Gulamarinjan, Dungalaba, Larrakia, welcome to Garamilla. Thank you. I invite Willie to come up and play the didgeridoo.
Thank you both for that absolutely heartwarming welcome to country. I thank you for your time and for being here this morning. Thank you. I'd now like to welcome Dr. Kristen Connors, the Chief Health Officer of the Northern Territory, to officially welcome the day. Thanks, Kristen.
Thanks, Renae. Good morning, everyone. Welcome to this year's annual Education Symposium hosted by the Diabetes Across the Lifecourse Northern Australian Partnership. And I'd also like to thank Larrakia Nation for that really wonderful welcome to country. I'd also like to acknowledge that we have many people online and they're in many nations around the country. So we've got our satellite sites in Alice Springs on Aranda country with quite a few people gathering, and also another satellite site in Cairns on Yirraganji country. So welcome to everyone online. It's a really large crowd joining us today, which I think is a real credit to the team from the Diabetes Across the Lifecourse Partnership. So some of you might remember, going back in history, that this current partnership started as the Northern Territory Diabetes in Pregnancy Partnership in 2011. And that brought together clinicians, researchers and policymakers to ensure that we could not only generate good evidence, but that we actually translated that into practice. And of course, what we're all interested in is getting better outcomes for the women and families that we work with. So I've been involved with the collaboration since those early days as Chief Investigator, and it's been amazing to see the contributions that the impact of the Diabetes Partnership and the Pandora study have had. And then since that time, we've now expanded beyond Northern Territory to Northern Australia, and we've also expanded the focus. And so now we are also looking at type 2 diabetes in children and young people. And that expansion of the focus really occurred because of yourselves and your predecessors. It occurred because of the interest and the engagement of clinicians in particular, but also researchers, Aboriginal advisors who kept pointing out concerns and issues that they had, which then led to identifying and expanding into new topics. So keep that in mind today, because you may well be able to spark interest and thoughts about new directions that are not currently being considered. So despite all of the changes that have happened over the last decade or more, the purpose of this day remains the same. It's a chance for all of us to come together, reflect on the work, and as I said, consider what's next. So I hope you enjoy the day. In fact, I'm sure you'll enjoy the day. And I'd like to now hand over to Associate Professor Renae Kirkham, who is the lead of the Diabetes Across the Lifecourse, and Ms. Sian Graham, who has been the chair of the Partnership Aboriginal and Torres Strait Islander Advisory Group for many years and doing an extremely good job. Thank you.
Thank you, Christine. I think it's really important to acknowledge that Christine's been around from the very beginning, since 2011, where she supported Professor Louise Maple-Brown with the establishment of the partnership, and has been a tremendous advocate and support of the work that we've done, particularly in the policy and practice space. So thank you, Christine, and it's tremendous to have you here this morning. Thanks. I'd like to start as well by acknowledging the traditional custodians of the lands on which we're all meeting today. So in Darwin, we're meeting on Larrakia country, so I acknowledge the Larrakia people. I also acknowledge the traditional custodians of the land in Central Australia, in Alice Springs particularly, where we've got people meeting today, the Aranda people. And I also acknowledge the Gimwe, Woolabara, Udinji people of Cairns and their surrounding mobs. I pay my respects to elders past, present and emerging, and I also respect and pay my acknowledge all of the First Nations people who are joining us today online from across Australia, but also those who are joining internationally as well. We have over 230 people who have who are attending today, either online or in person. And as Christine said, we've got satellite sites in both Alice Springs and Cairns, which are being hosted by our teams in those two sites. For those joining online, I just have to do a little bit of housekeeping. Sorry, it's part of the start of the proceedings. For those joining online, we've set it up so that everybody's cameras and microphones are in fact switched off, but we'll ask those who are presenting online to switch on their cameras when they're presenting. And if you want to offer a comment or a question, please use the chat function. We have a number of people from our team who will be moderating throughout the day and be able to feedback those questions to the chair as best we can. We know that we may not be able to address all questions, but we will do our very best. For those who are here with us in Darwin in this auditorium, thanks for coming. We'll keep the front door here closed once the sessions have commenced, just to try and minimise traffic and interruptions through the front area here. The toilets are in the foyer directly sort of behind the auditorium here, and we really ask people to come back into the session really promptly after breaks, because we've got a very tight schedule today and we want to respect the time that everyone's been allocated to give their presentations and talks. In the unlikely event of an emergency, we have there's an exit over here, and please just make your way out through the front main doors and you'll be escorted out to the relevant muster point. I feel like an air hostess. As Christine has already flagged, the theme for this year's symposium is improving care for diabetes across the life course. And this theme was really developed in response to evaluation findings that we've had over the past few years from our symposiums, and that includes the 2022 Diabetes Summit in Alice Springs, where a number of people, particularly clinicians, have been asking for more practical recommendations and links to evidence around how their diabetes practice and management can be improved, particularly given I guess in terms of the partnership, we have now expanded from looking at diabetes in pregnancy into the youth type 2 space, which is quite new when we think about type 2 diabetes management, now looking at young people. So we have, the program has been informed or developed based on that, those requests. We've also been very, very fortunate and excited to be joined by two impressive keynote speakers today. So we've got Professor Kristen Nadeau, who will be joining us online from Denver, Colorado, and also Professor Helen Murphy, who's up the back, who's joining us in person, which is absolutely tremendous. So they will both be sharing some of their research and clinical expertise related to youth type 2 diabetes. That's Kristen, and then Helen will be talking specifically around some of her fantastic research in the diabetes in pregnancy space. We also look forward to, we have two expert panel discussions, one that's facilitated by Dr. Angela Titmuss looking at youth type 2 diabetes, and then also Dr. Matt Hare looking at diabetes in pregnancy, and then an update by Dr. Anna Wood, who's on our long-standing Pandora study. Then this afternoon, we have a workshop for those who have registered, which will be facilitated by leaders from the National Centre of Implementation Science. And the focus of this session is really practical, and we'll be supporting attendees to workshop different ways to support the sustained implementation of chronic disease prevention initiatives, particularly in the diabetes space, in community settings relevant to our Northern Australian context. This will be really highly relevant to our program of work across the Diabetes Across the Life Course partnership, and we'll be madly taking notes to think about different ways that we could be doing our business differently in partnership with our key stakeholders and health service partners across the North to ensure that the work that we do is being translated and done in appropriate ways that meeting the needs of everybody involved. And the workshops, just to finish off there, the workshops are available to those here in Darwin and also those joining in person in Alice Springs and Cairns, because they have facilitated discussions and we were unable to make that happen online. But we have very good numbers, so thanks to those who will be joining. For those who are wanting to join, get Wi-Fi access, they are the details there. Give you a moment to screenshot or take a picture. As many of you are well aware, we have some of the most devastating diabetes outcomes prevalence in the world. And so Dr. Matthew Hare and Dr. Angela Titmuss have been instrumental in publishing recent manuscripts highlighting some of these rates. So in Central Australia, 1 in 3 adults are living with type 2 diabetes, and this was work that Matt recently published. So 40% of adults in remote Central Australian communities are living with type 2 diabetes. These rates have doubled in the last 15 years. We also have documented that there's a higher prevalence of diabetes among Aboriginal women than men, and there's been a substantial growth in the prevalence of Aboriginal women who have been diagnosed with type 2 diabetes prior to their pregnancy, which really amplifies the reason why our work in the diabetes in pregnancy space is so important. In the youth type 2 diabetes space, Dr. Angela Titmuss has recently highlighted in a recent publication that in Central Australia, again, unfortunately, 1 in 70 young people under the age of 25 have type 2 diabetes. And this is the highest rate in the world for young people that's been recorded, which is 20 times higher than non-Indigenous young people in the same jurisdiction. So the work of our partnership, as you can see here on this slide, is really we aim to break the cycle of type 2 diabetes and related conditions. And 2 of our major programs of work, as I've just mentioned, are on breaking the cycle of diabetes for youth with type 2 and also within the diabetes in pregnancy space. The other 3 priorities that we have are around prevention and improved management of obesity and diabetes across the life course. The second priority is around strengthening community engagement in a life course approach to diabetes, focusing on preconception, pregnancy and youth. And the third is to strengthen the Aboriginal and Torres Strait Islander community-based workforce in diabetes. And just to flag there that it's not just the Aboriginal and Torres Strait Islander health workforce, we're really acknowledging that it's a community-based workforce that's absolutely integral to finding the solutions here as well and enhancing management and prevention. This slide really serves as a good reminder of the many risk factors of developing type 2, which many of you are well aware of. Some of the risk factors we know are related to ethnicity and family history, but also importantly, the social determinants of health. And last year's symposium, we really focused on the social determinants of health, the impact that they have, and also the impact that that has on mental health with the prevention and management of diabetes. But today we'll be drawing on the relevant research and expertise to support the appropriate clinical management for First Nations people living with type 2 diabetes and also those living with diabetes in pregnancy. We have a short video that really quite eloquently sums up the work of the partnership and who we are. So it's only 2 minutes. I am going to attempt to share it with you and hope it works for everybody.
Diabetes, my story, our journey. We can read it together.
The Diabetes Across the Life Course Northern Australia Partnership is a collaboration of researchers, health service providers, policymakers and community members. Together, we are working to address the intergenerational epidemic of diabetes among Aboriginal and Torres Strait Islander people. Families and communities affected by diabetes and related chronic conditions are at the centre of all that we do. The partnership, based at Menzies School of Health Research in Darwin, was founded in 2011 and now has teams and collaborations across Northern Australia. For our research and translational efforts to be effective, appropriate and sustainable, we prioritise Aboriginal and Torres Strait Islander governance through the advisory group, community engagement and privileging the voices of people with lived experience. In all our projects, we integrate knowledge translation activities and opportunities for two-way learning, capacity building and training. Our research highlights the importance of a life course approach to preventing and managing diabetes, with a particular emphasis on the health of young people and women before, during and after pregnancy, as this impacts multiple generations.
Diabetes, my story, our journey, we can beat it together.
So our work has identified and advocates for many solutions required to addressing our vision and breaking the cycle of type 2 diabetes. Important to these solutions is ensuring that the ways we work support meaningful partnerships and shared responsibilities required to prevent and manage diabetes for Aboriginal and Torres Strait Islander people in the Northern Territory. Our governance structures are a key component of this. For example, our joint decision-making is provided by the Aboriginal and Torres Strait Islander Advisory Group and the Partnership Steering Committee. So this committee is made up of key stakeholders, study investigators, health service partner representatives, and policy makers. The partnership currently employs over 42 staff and supports 12 high degree research students. We are a large group based in Darwin, Alice Springs and Cairns. We want to acknowledge the tireless work of all our staff and students of the partnership who are critical to all of our work aiming to break the cycle of type 2 diabetes and related conditions. The large program of work undertaken in the partnership falls under three broad categories. The first is understanding the intergenerational burden of cardiometabolic conditions. We have 4 key studies that sit in this theme, as you can see. We also have 2 current studies that fit under the prevention projects and 3 studies that sit within our implementation project stream. So since our last symposium, which doesn't really feel like it was that long ago, it was in November, we have had a number of research highlights and successes, which I'm really keen to share with you. So probably one of the biggest ones was that our work collectively informed the parliamentary inquiry into diabetes. So we put a submission in August last year, and then we were subsequently invited to present evidence at the hearing in March. This evidence informed many of the recommendations that were made by the report, with our submission cited 10 times and members of the partnership directly quoted from the hearing 8 times. So I feel like that's years of work that has gone into getting us to that point, but it's just absolutely fantastic that there has been an opportunity to be able to provide evidence at that level, and it's been taken up in terms of those recommendations. Our work's also recently been used to inform several of the recommendations that were made in the Diabetes Australia's The State of the Nation 2024 report. So 6 of our peer-reviewed publications were used as evidence to support recommendations, particularly those advocating for improved diabetes prevention, management and outcomes for Aboriginal and Torres Strait Islander people. So well done, team, and all of our collaborators and stakeholders. That's, yeah, as I said, that's years of work that has informed those important documents and recommendations. Since December, I'm very pleased to say that as a group we've published or have had accepted 10 new papers, and they're in peer reviewed journals. So there's a couple of them there. I'm just going to move that little image over here if that's okay. You can access all of our publications on our website. There's a list there, and just to note as well that since the establishment in 2011 of the partnership, the first academic paper was published in 2013. Of course, that was led by Louise Maple-Brown. And since then, we've had over 60 manuscripts that have been published. So in recent times, it's growing, which is clearly the nature of how these things develop. But absolutely, we need to acknowledge all of the hard work that Louise did at that point and continues to do in supporting us with all of the work that the team continues to do every day. We also have a number of higher degree research students who have either recently submitted or completed or commenced. So we have there Dr. Anna McLean based in Cairns. She's the first image on the left. And Dr. Diana Mackay, who is in our audience here in Darwin. Both of these amazing women submitted their PhDs recently and they are currently under review. So we wish them the very best of luck there and hopefully we get some good news soon. And Corinne Butler, she did a master's project with us recently, which was received excellent. She got a high distinction, which we're very proud of. And yeah, just incredible to have this great group of students working in the team. Also, Kim Martin and had just started her master's project with us, and then Emma Weaver and Mary Lynn Carino, they've both just enrolled in their PhDs. So we definitely have more amazing students coming through, which is where a lot of our work comes from. So thanks everybody for your contributions there. Just to flag, our work obviously also relies heavily on the grant funding that we obtain, and that's a lot of the hard work that we do behind the scenes. We've had a couple of grant successes in recent times. So Anna Wood has led a successful grant to MRFF, which is really to the continuation of the Pandora study. So that's a pilot of Wave 3, which she will talk about later this morning. And I'm leading a recently funded piece of work on the youth type 2 diabetes, which is really informs the next phase of our type 2 work. We commenced that a few years ago. This is the next phase of funding. And Angela Titmuss is also leading another grant in the youth type 2 space, which has recently received funding. And then we have a number of fellowships which also support the work that we do, with special mention there of Louise Maple-Brown and Angela Titmuss and Anna Wood. We are actually have a little bit of time up our sleeve, which is unheard of. I was very nervous that we would start late and be running late. We've got Kristen online planning to start at 9 a.m, but I do wonder, we have a really great youth type 2 video that we could potentially show at this point, which goes for 4 minutes. If everyone can bear with me while I get that up. This is unheard of, I think, and especially for me.
Hi, my name is Teresa and I'm from California, and I had diabetes type 2. I found out I had diabetes when I was 16, at a young age having diabetes. I didn't know anyone that had diabetes. I felt like I had nobody, had no support, but I was wrong. I did have a lot of support. I was feeling a bit lazy, tired. That's why I went to the clinic to get checked up. They did all sorts of tests.
Do you remember when you went into Catherine Hospital and you were really unwell? So they did a special blood test. You've probably heard the nurses talk about it. It's called the HbA1c. And that's a marker of telling us how much sugar or glucose is in your blood. And so when you went to hospital, it was right up there. And that's really at the height of your sickness when we realised there's something wrong. And so we sent you into Catherine, and you had medications, you had metformin, you started on insulin, and you started to feel better. And then you came back to community, and I remember you telling me that you didn't want to take these medications anymore, and you didn't want to take the insulin.
I had to get up and do something and just like do something about it. I thought like, I don't want to have diabetes. I need to beat it.
Started to make changes, and you said, I'm going to take control of my diabetes. I want to be the boss. So you started walking and changing the way you were eating. I tried so hard every day. I watched what I was eating. I would start eating healthier. I start making me feel healthier and all that. Enjoying the fruits, enjoying what I'm eating. Healthier food, healthy everything. It's just great.
I felt tired going for a walk all the time, but I just forced myself to be active, not being lazy, just go for a walk.
You've put your diabetes into what we call remission. That means you've stopped on it, you've stopped it, and you've become the boss of it. And doing all those things, every time we do a blood test on you to see how your blood sugar story is, it's perfect. It's exactly where we want it.
When you guys are feeling lazy or just get up, force yourself to get up, take a walk or anything like that, just do something active, go play sports, or you can do anything. Eat healthy, be healthy, and do what best that you can do. Even though if you have diabetes and all that, there's still something more active and all that, like what I'm doing, walking and all that, or play sport or do whatever you want to do, and just keep yourself active and just be you. Don't listen to your down dogs, like you got no supports and all that. You do. You got a lot of supports. Don't ever feel yourself left out or down. Yeah.
I think you will all agree that that is an incredible success story and one that we really want to see more of. Thank you, Matt, and your team, and also the youth team for making that video happen, along with all of our partners who were involved. I think we might see if Kristen is ready to join us for her online presentation on Zoom. And perhaps while you're doing that, would you like to introduce her? So Professor Kristen Nadeau is an Indigenous Professor of Paediatric Endocrinology and the Vice Chair of Clinical Research for the University of Colorado's Department of Paediatrics. Her research focus is on reducing long-term complications of diabetes, inactivity and obesity in youth, including mechanisms of insulin resistance, cardiovascular disease, exercise dysfunction, diabetic kidney disease and fatty liver disease. Kristen's research has a particular focus on youth onset diabetes, and she has worked on the Today trial, which is a prospective randomised trial involving institutions across the US to evaluate treatment regimes in the clinical course of type 2 diabetes in youth. It's a family-based longitudinal study of youth onset type 2 diabetes for those who are not familiar with the Today study. Kristen's early interest in diabetes came during her medical training when she saw the growing rates of type 2 diabetes among the Native American population and the first youth that were being diagnosed with type 2 diabetes at that time. Can I hand over to you, AG, to...
Just check that Kristen's good to share her screen from her end there.
Yeah, I can go ahead and share. Can you hear me okay?
We can.
Okay, great. I will do that.
Thanks, Kristen. We'll let you do your thing.
Do you see the presenting view?
Yes, we can.
Okay, perfect. Well, thank you very much. I'm really honored to be asked to join you and share some of the things that we've been working on in the United States, and wish I could have been able to make the trip out there to learn more about what's going on in Australia, but really look forward to the opportunity at some point in the future to being able to do that. So I am, I don't have any disclosures, but I would like to start by acknowledging the fact that the lands I work on at the University of Colorado were the prior homeland to Cheyenne, Arapaho, and Ute nations, Native American tribes, as well as 38 other indigenous nations. And as was mentioned in my introduction, what got me interested in the field of diabetes is on my father's side of the family, I'm Prairie Band Potawatomi. And so that's really what drives me to want to try to help prevent and treat diabetes. So there are a couple of myths out there, I think, that I just am hoping that after my talk today, maybe I can convince you of otherwise. And that's that there's a fact is that cardiovascular disease, unfortunately, is the #1 cause of death in people with diabetes. But the myths are that youth onset type 2 diabetes should be thought of as just an earlier version of adult onset, just in a younger population. And that also that interventions done in adults are too aggressive for kids. And unfortunately, we're finding complications so early such that it's probably the farthest thing from the truth. So I just wanted to start with 2 cases just to illustrate one of the struggles we're having, at least in the United States, because of the fact that the rates of obesity are rising in all kids, is when we're presented with a youth with new onset diabetes, what kind of diabetes is this? Because with obesity, it's also increasing in type 1 diabetes populations. And so the first case, this is a 10-year-old girl who presented with polyuria and polydipsia, had a BMI of 31. She had acanthosis, or darkening of the skin at the neck that might be suggestive of insulin resistance, and was pubertal. She was Tanner stage 3, so midway through puberty. Her family history has some autoimmunity with hypothyroidism that might make you think of type 1 diabetes. And she did have evidence of TPO antibodies. Her family history, there was some overweight and hypothyroidism on in the parents, and then the grandparents had type 2 diabetes and hypertension. So kind of a mix of risk factors. She presented with an A1C of 12, fasting blood sugar of 250, and did have ketones and a low pH. So those might make you start thinking more of type 1 diabetes, but we see kids that have DKA and do have full acidosis and severe hyperglycemia at the presentation of their type 2 diabetes. She had triglycerides of 450. That doesn't help a whole lot in differentiating type, because triglycerides can be high at presentation when there's severe hyperglycemia. Although generally, if diabetes is in better control, we don't tend to see high triglycerides in people with type 1 diabetes like we do in type 2. The HDL is a little bit of a clue, being low, because we tend to see that much more often with type 2 diabetes than type 1. Her LDL was normal. She had elevated liver enzymes, in particular the ALT, that would be suggestive of what had been called non-alcoholic fatty liver disease, but now is being called metabolic associated fatty liver disease. And that, again, is more common with type 2 than type 1. So ultimately, her age being 10, her autoimmunity and her severity of presentation might have made you think of type 1. But on the other hand, she's pubertal. So she could have type 2 diabetes, as we tend to really see type 2 much more often when puberty starts. And she does have some risk factors for type 2. And then on her labs, that low HDL and high ALT were tipping us towards type 2. And so what we did on her was we checked antibodies. She was started on insulin initially because of the severity of her hyperglycemia. but also given metformin while we awaited the antibodies. And then it turned out her antibodies were negative, so she did have type 2 diabetes. And so then what happened next is that with type 2 diabetes, usually once you get the acute hyperglycemia under control and get on other medications, the insulin can be withdrawn pretty quickly. And that was what was able to be done, is that her insulin was weaned away very rapidly once metformin had been in place. And then she was actually able to be maintained with just metformin. So in contrast, the second case, this is a 13-year-old boy, and he also had polyuria and polydipsia. He had some overweight in the family, also had a mom with hypothyroidism and grandparents with type 2 and hypertension. So these family histories are basically almost exactly the same, and these are real patients. So this is a true description. He had a little bit of hypertension, and then his BMI was similar at 33, but he was prepubertal. Being age 13 as a boy, you could be pubertal or not, and he was not. So that made me think that this is a little less likely that he's going to have type 2 diabetes despite his BMI and despite the type 2 diabetes family history. On his labs, he had a very similar presentation of hyperglycemia, which might tip towards type 1. But different from our first case, he had normal liver enzymes. His triglycerides were only mildly elevated, and his HDL was normal. And in his case, he turned out to have positive antibodies and have type 1 diabetes. But again, if you just heard this quickly on the phone, hey, I've got a kid with a BMI of 33 who's got a family history of type 2 diabetes, you might think, oh, slam dunk, this is going to be type 2. And in his case, it was not. And so he was started on insulin initially as well because of the high A1C, but once the antibodies came back and were seen to be positive, then he was considered on or continued on insulin. But one thing that might be considered in this case, in addition to lifestyle management, of course, because he still has this high BMI, is potential adjunctive agents, and whether as we move into the future, we're doing research studies now on the use of metformin and GLP-1 analogs, et cetera, in type 1. But I think the main take-home message here is it's not as much like what kind of diabetes is this, but it's more something we have to figure out is what does this patient need? And so if they need obesity treatment, they need that. If they need insulin, they need that, et cetera, and trying to tailor the treatment towards what their presenting labs actually are. So then I'm going to switch from these hypotheticals to data that we have starting from the Today study that was mentioned initially. So the Today study was the largest study in the United States to date of type 2 diabetes in kids that enrolled 699 youth. And what we learned from the baseline data from the Today study is basically just the general characteristics of kids with type 2 diabetes in the US. And on average, this group was 14 years old. Their duration of diabetes by definition was short in order to enter the trial. So it had to be less than 6 months, and on average, it was 5 months. The BMI score was in the overweight to obese range. Of note, there was a female predominance, so more girls than boys. And this, as you'll see, as I talk about some other studies, continues to bear out to be what we see in the United States. And I'll talk about that a little more in the next slide, but this is different than what's seen in adults, where there tends to be similar or even a little bit of a male predominance. The racial ethnic mix of this group was very diverse, with a lot of minoritized groups, including a predominance of kids that are Hispanic, African American, or American Indian. And a very high rate of family history of diabetes, nuclear, meaning the parents or siblings, 60% of them. And if you extend out to grandparents, now 90% had a family history of diabetes, and a third were exposed to gestational diabetes. So why that female predominance? We don't know the answer for sure. One quick answer is that girls go through puberty about a year earlier. So a little bit of it is artifactual from the fact that girls are biologically older at whatever age they are as a teenager than boys. So puberty starts earlier in them, which is a trigger for insulin resistance. But in addition, what we've seen in a couple of physical activity studies done in the United States, this is the NHANES study, which is a large population study being compared to the Today study. In the pink box on the left are the girls, and the blue on the right are the boys. And at any, whether they're you know, in any age group, they are less active in the girls. And then my colleague, Megan Kelsey, did a study where it's a small sample size, but it was intriguing, where she looked at physical activity in girls versus boys by pubertal stage. So at Tanner stage 1, which would be pre-pubertal, there was no pattern between boys and girls. But then when there was onset of puberty at Tanner stage 2, there was a spread where the boys are now at the top end of activity, girls at the bottom, and this was true again at Tanner stage 3. And so, you know, there's a hint here that something's happening when puberty starts in girls, whether that's just societal, that, you know, girls just aren't included as much in sports, or, you know, the effects of growing up in modern society, or whether there's something biological that drives girls to be less active, potentially to put on more fat and be able to be in a reproductive state for pregnancy, or some combination needs a lot more work. But this is something that we need to understand and be able to battle to try to help reduce the rates of diabetes in these girls. So when we look across section at adolescents with type 2 diabetes, what we see is that the metabolic syndrome is quite prominent in them. And what I've displayed here is a group with type 1 diabetes that are adolescents that have normal weight, a group with type 1 plus obesity, and then a group with type 2 diabetes. And in comparing them cross-sectionally, what stands out is that those with type 2 diabetes have the highest ALT, or liver enzymes suggesting a fatty liver, the lowest adiponectin, and then also have the highest triglycerides and the lowest HDL. And this is different than what we see in type 1 diabetes, even when it's type 1 plus obesity. So although people with type 1 diabetes do get worsening in some of these metabolic syndrome characteristics when BMI gets higher, they still don't look like they've got the full-on metabolic syndrome that is seen in type 2 diabetes. Our group has looked in more depth at trying to understand tissue-specific insulin resistance in adolescents with type 2 diabetes, but compared to different groups. And it's interesting if you look at the breakout. So in this top graph is a group of lean control youth in purple, so normal weight kids without diabetes, followed by those with obesity in the royal blue, normal weight type 1 diabetes in green, overweight plus type 1 in yellow, and then type 1 plus obesity in aqua. And then finally in the red is type 2 diabetes. So these are results from a hyperinsulinemic euglycemic clamp where we infuse insulin, and then we look at the glucose infusion rate that it takes to maintain normal glycemia in response to an insulin infusion. So the higher the rate, the more sensitive you are to the insulin. So the kids with type 2 diabetes are the most insulin resistant by this measure. But it's interesting also that within type 1 diabetes, we actually see quite a bit of insulin resistance. Even in those who are normal weight, their insulin sensitivity is less than a child with obesity. And once you get down to obesity plus type 1 diabetes, it's almost the same insulin sensitivity as we see in type 2. But it looks like the mechanism of insulin resistance in type 2 diabetes is different than type 1 because, like I said, that lipid panel and the other markers of the metabolic syndrome are different. So we know kids with type 2 diabetes are very insulin resistant when we look at the whole body. In addition, we've documented that kids with type 2 diabetes have mitochondrial dysfunction, and it correlates with their glucose infusion rate. So lower mitochondrial function in the calf muscle correlates with having lower insulin sensitivity. We've also added tracers to these hyperinsulinemic euglycemic clamps to try to look at adipose and hepatic insulin sensitivity. So using a glycerol tracer, which allows us to look to see whether when you give insulin, which should suppress lipolysis and drop the production of the release of glycerol and triglycerides into the bloodstream, that when you give insulin to a normal weight population without diabetes, they get a very quick drop in glycerol release, which is what the normal response should be once insulin is present. But in type 2 diabetes, there's very little response at a low dose of insulin, and even at very super physiologic insulin doses, they still don't completely stop lipolysis. And this is similar to what's seen in adults, that there's adipose insulin resistance in kids with type 2 diabetes. Interestingly, we see this also in type 1 diabetes. And in the kids with type 2 diabetes, when we look at the relationship between the glycerol and free fatty acids, they do correlate with whole body insulin sensitivity. So it may be that these elevated free fatty acids that are present in the bloodstream are causing insulin resistance in the muscle. And then finally, when we add a glucose tracer to the insulin clamp, similar to the adipose, what you would expect is that when you're fasting, you have a lot of glucose released from the liver. And then when you give insulin, that should go down. And we can measure that by adding a glucose tracer, and the unlabeled glucose is coming from your liver versus the label from the IV. And again, in a lean control group, once we turn on insulin at a moderate or high dose, all of the glucose output from the liver drops off. But in type 2 diabetes, it stays quite elevated. And so another feature of type 2 diabetes in kids is that the liver is not responding to the insulin. And therefore you're having continued glucose output, which contributes to hyperglycemia. And again, this finding is not unique to kids. This is also what's seen in adults, and it's also what we see in kids with type 1 diabetes. So this multi-tissue insulin resistance is present in all of these groups. What's different, though, when we compare type 1 to type 2 is the location of fat. So we've done MRI in the liver as well as the abdomen to look at visceral fat, and within the skeletal muscle to look at intramyocellular lipid. And what we find is that as obesity starts, you get a rise in liver, visceral, and intramyocellular lipid in yellow. But those with type 2 diabetes have much more fat in these areas. So this, again, is the metabolic syndrome of abdominal adiposity. And this is true in the muscle as well. But in type 1 diabetes, we do not see an increase in the liver and visceral fat or in the muscle, at least in people that are more of normal weight. So again, pointing to a different mechanism of insulin resistance in type 2 diabetes, and therefore likely different treatments that are needed. Finally, our group has shown some really early evidence of cardiovascular dysfunction. Near diagnosis, we've shown that kids with type 2 diabetes have elevated C-reactive protein, so evidence of inflammation as well as IL-6, and they have low adiponectin, as I showed you earlier. And then when we look at their heart and the blood vessels, they've got increased cardiac left ventricular mass, a low peak exercise capacity, and then in their hearts have evidence of circumferential strain, so systolic dysfunction, as well as abnormal vascular reactivity, which is shown in the graph to the right. And this is in comparison of BMI matched adolescents, as well as those of normal weight. So a lot of abnormal findings that are concerning early on, shortly after diagnosis. If we flip back to the Today study, what the Today study actually did was randomized kids to either metformin alone, metformin plus an intensive lifestyle intervention, or metformin plus the thiazolidine-dione rosiglitazone. And what was found in the Today study was that there was quite high rates of failure of these initial oral therapies. And shown on the right is the survival curves where proportion that are free of glycemic failure are presented. So at the beginning, everyone had a good range A1C. And then what happened over time, just over a couple of years, about half of them had failed their oral therapies and needed to go on to insulin. And we did find some differences by treatment group. The rosiglitazone group in the red did do the best, and the metformin alone did worse, with lifestyle being intermediate. But what was interesting is when we broke that out by sex, the response was the opposite. So the girls actually did not respond well to lifestyle, and instead they were the driver of that better response to rosiglitazone in the red dotted line, whereas the boys had the opposite. They had a better response to lifestyle, and rosiglitazone was no different than metformin alone. And this might go again with this theme of girls doing less exercise. And in fact, when we looked at the accelerometry data and the attendance to the exercise sessions, the girls did less activity. So I don't think we think that exercise doesn't work if you actually do it, but just that the girls didn't participate as much. And then of note, these failure rates that I'm showing you are much higher than what's been published previously in adults. So if we compare it to the ADOPT study of metformin treatment in adults with type 2 diabetes of the same duration, they had a failure rate of 12% versus the 52% that was seen in Today. So for some reason, these adolescents are not responding as well to the medications that were used in adults. Today then went on for almost 20 years. And so because of this long follow-up, we now have the ability to look at complications over time. And so depicted here is the 12-year cumulative incidence of some of the diabetes complications. So by 12 years, about 50% of the participants with youth onset type 2 diabetes had renal hyperfiltration, which is the early sign of kidney disease. The glomerular filtration rate tends to go up first and then fall as you get into the late stages of kidney disease. About 40% had evidence of proteinuria as another sign of kidney disease. And then if we look at the complications clumped by type, out to 15 years, about almost 70% had hypertension. Overall, some kind of kidney disease was present in 55%, dyslipidemia in 51%, and then nerve disease is the lowest, but still about a third of them had evidence of neuropathy. And if you put together all microvascular diseases, 75% had at least one present. And then looking at the eye disease, by the same length of follow-up, about 51% were starting to show evidence of retinopathy. And then of huge concern, there were 17 serious cardiovascular events. We had 4 heart attacks, 6 episodes of heart failure, and 3 coronary artery disease events and 4 strokes. And there were also 6 deaths that were thought to be related to diabetes. And as a reminder, the average age here when entering was 14. So this means that now about 10 to 15 years later, these participants, when these events were occurring, were 25-ish. And so this is an age when you would be expected to be at the peak of health and reproducing, and instead we're having these really concerning early serious events, and at a much faster rate than what's been seen in adults. And then the other thing that was very concerning was what happened with the pregnancies in participants of the Today study over time. We did frequent contraception education and provision of contraception. But despite that, the pregnancy rates were around 10% and 30% had more than one pregnancy. These rates are actually not different than other adolescent pregnancy rates. However, what was different is the outcomes. So about 22% of these pregnancies were large for gestational age, about 6% small, and about 23% preterm. These are all 4 times the general population rate, but not different than what's seen in adults with diabetes. But what was different than even adults was the rate of congenital anomalies. 21% of the pregnancies had a major congenital anomaly, of which half were cardiac. And this is 4 times the rate that's been published in adults with diabetes. So not only are these youth themselves having serious complications, but they're then passing on obviously the increased risk of diabetes to the offspring, but also actual congenital anomalies to their youth. And of note, when these data were starting to be seen in Today, we were very concerned and adopted a more intense intervention as far as trying to prevent having unwanted pregnancies. So there was a program that we instituted that was trying to help do more intense education to be ready for pregnancy. And there was a spin-off of that we then did that was with the American Indian population in the US. And we've created handouts and things like that that can be shared from that work that we're trying to prevent gestational diabetes in an adolescent population. So due to those pretty discouraging results from the Today study, there was another large NIH study that I participated in that was saying, hey, did we intervene too late in Today? Should we do it sooner? Should we be starting treatment when it's just at diagnosis or at the state of impaired glucose tolerance? And so that was what the RISE study and all the participating centers are pictured here. So in the RISE study, we wanted to also look at youth versus adult head-to-head. So we recruited a group of adolescents and then a group of adults. And the adolescents and the adults could have either prediabetes or type 2 diabetes, but of very short duration. And what happened is that they underwent insulin sensitivity and secretion testing, and then they were randomized either to metformin or to intensive insulin therapy for 3 months, followed by 12 months of metformin. So there was a year total of treatment. And then a washout period where the medications were stopped to try to see what happened after stopping. And the idea was if we could rest the beta cells hypothetically with insulin, followed by insulin sensitization with metformin, or just metformin alone, based on the adult DPP diabetes prevention study, which showed that using metformin prevented progression of prediabetes to diabetes. Could we interrupt this process, and how did that look like if it was kids versus adults? So these are the participants in the RISE study, and of note, there was a female predominance in the kids, like I said, happened in the Today study, and that was not the case in the adults for RISE. And also the kids had much more representation of historically underrepresented or minoritized groups of importance. The BMI was the same in the kids versus the adults, and that was by design because we wanted the groups to be comparable. And then, of course, the ages were different by design. So they underwent a hyperglycemic clamp pictured here. And what this means is they got a bolus of glucose. They had a blood sugar held at a range of around 200 for 2 hours. And then they got a second bolus of glucose followed by a bolus of arginine. And the purpose of this test is to look at your insulin and C-peptide secretion in response to mild hyperglycemia and then more extreme hyperglycemia followed by the amino acid arginine. And both the glucose and the arginine should stimulate insulin secretion. And what we saw was that despite the fact that the glucose levels achieved between adults and kids were identical by design, the kids in the dashed line made much more C-peptide, whether fasting or throughout the clamp, and then a much larger response at the maximal insulin secretion. And we also did an OGTT on them. By design, they had similar hemoglobin A1C and fasting glucose at entry. So their OGTT glucose curves between kids and adults were nearly identical. But despite the fact that they had similar glucoses, the C-peptide secretion in the kids in red was higher than the adults in blue. And if you look at insulin, same thing, much higher insulin secretion. And so one of the theories is that because of the fact that kids are more insulin resistant, they have to make a lot more C-peptide / insulin in order to keep glycemia the same. And that maybe this is why we're seeing the rapid beta cell failure because of the amount of work it takes to make all of that insulin and C-peptide. And why are these adolescents potentially more insulin resistant than the adults? This is from work in Minnesota in the United States from Tammy Moran's group and Alan Sinaiko. So this is an old study, but what is shown here is if you do a hyperinsulinemic euglycemic clamp, like I showed you earlier, in girls versus boys, what happens at different puberty stages. And what they found was that it's extremely tightly correlated with IGF-1, which is a marker for growth hormone secretion. So basically, as your growth hormone goes up, your insulin sensitivity goes down, and there's no sex difference. This is happening in both the boys and the girls. So if you think of adolescents and type 2 diabetes in adolescents as similar just to gestational diabetes, there are a lot of parallels. In the pregnancy, chorionic somatomammotropin or placental growth hormone goes up, and in puberty, growth hormone goes up, and they're both happening for physiologic reasons. And you get a drop in insulin sensitivity in response to that. And it's probably appropriate because you want to drive the blood sugar a little higher to get a source of calories for the baby, or in the case of puberty, to have that calories available to be shunted towards growth. But if you have a combination of this insulin resistance and obesity, which is unfortunately what we see in today's society, in some kids, this is just too much of a demand on the pancreas. The one good thing is that it could go away, like gestational diabetes, when the insulin resistance of puberty is resolving. There's hope for improvement. But the concern is that if it happens enough such that there's more permanent damage to the beta cells, it may not be recoverable. So in RISE, we treated, like I said, with metformin alone, as well as insulin followed by metformin. And basically what we found was that metformin improved blood sugars in kids and adults. So it worked just fine while they were taking the medication. But as soon as it was withdrawn, which is in this dotted line after month 15, the A1C shot up after it was withdrawn, so there was no legacy effect. And then in the BMI, there was weight loss a little bit with metformin. But interestingly, after the metformin was withdrawn, the adults kept the weight off, but the kids did not. They gained it right back. And then in the group that got insulin in these two green graphs, again, insulin lowered blood sugars, so it worked in both groups. And once you stopped the treatment, it came right back, so there was no permanent effect. But what was different was that with the weight gain in the kids, while they were taking insulin, they gained weight and the adults did not. And then once the insulin was stopped, the adults started losing weight and the kids never did. So at the end, when we stopped therapy, the kids ended up at a higher BMI than they began, whereas the adults kept the weight off. And so this gives us some kind of pause and caution in thinking about using insulin for very long in kids with type 2 diabetes, because it seems to really be driving weight gain in them. And one of the reasons may be the dose of insulin that's required. So as I showed you, the kids are so insulin resistant compared to the adults. And when we look at what the actual dose of insulin it took to maintain blood sugars, it was a really high dose in the kids. So if we look out after 3 months of treatment with glargine or Lantus insulin, long-acting insulin, which is what we used in the RISE study, the dose was around 0.7 units per kilo per day. And the kids on average were about 100 kilos. And so they were getting about 70 units of long-acting insulin a day. And if you remember, half of these kids had pre-diabetes. So the interesting take home from this is a kid with pre-diabetes can take 70 units of Lantus and not have hypoglycemia because this was very well tolerated. But on the other hand, that's how much is needed to correct the blood sugar. And so that really may be driving weight gain in this group. So the final thing was the main outcome from the treatment as far as looking at beta cell function. What we saw in the adults is this is a disposition index curve where we've plotted M/I as a measure of insulin sensitivity relative to maximal insulin secretion as a measure of of insulin secretion. And what we saw in the adults is regardless of which treatment arm they were in, they stayed on the same line on the DI curve, which means that their beta cell function was stable during treatment. But in the kids, we saw that no matter whether they were on treatment at 12 months or off treatment, we saw a drop off in beta cell function, and it didn't matter which treatment arm they were in. So again, this is showing that interventions that seem to preserve beta cell function in adults are not effective in these kids. And it didn't matter if they had pre-diabetes at the beginning or if they had type 2 diabetes. So even treating at the pre-diabetes stage, they did not improve or even maintain beta cell function. And then a similar finding was found by my colleague, Megan Kelsey, who gave metformin treatment to kids that were early in puberty who had normal glycemia. So the idea here was, let's start even earlier. What about if there's obesity but normal blood sugars? And so she had a control group, a group with obesity, and then a group with obesity that got metformin. And unfortunately, after 2 years of treatment with metformin, although there were some small improvements in BMI and body fat, neither insulin sensitivity nor beta cell function was improved with metformin. And of those that flipped over into developing diabetes in her study, those that had the highest insulin secretion at the beginning were the ones that got diabetes. So having high initial DI predicted later decline, which is interesting and something that we need to be thinking about as we're trying to figure out who's at risk and who will develop diabetes. But based on Megan's findings and the findings from the RISE study, our group at least has stopped using metformin in pre-diabetes because it does not appear to be effective in preventing progression. But not to say that we don't use it when kids actually have diabetes, because it does help control blood sugars. So what did predict progression of glycemia? In the Today study, it was not insulin sensitivity. In the graph on the upper left, it didn't matter at all what your insulin sensitivity was if you failed or did not fail treatment. Instead, what mattered was your beta cell function. Those that had a worse insulinogenic index were the ones who failed. So it really looks like beta cell function is what drives failure over time in kids with type 2 diabetes. In RISE, glycemia worsened more in the youth versus adults, and the predictors were similar to the Today study. Lower beta cell function was predictive of decline. However, in adults, it also included insulin sensitivity. So in adults, if you were more insulin resistant, you also had more failure over time. But in kids, it was really the beta cells that were driving it. And then in this graph on the upper right is just also kind of depressing that this is showing during the Today study, if your A1C at the beginning was better or higher, it didn't really matter. We were wondering, like, does early better glycemic control help predict failure? And no, it didn't. Everyone just got worse over time. It didn't matter where you started. Insulin sensitivity was completely flat. So it didn't matter where you started. It just didn't change. And what did matter is your initial C-peptide index or your oral disposition index. But everyone tended to decline over time, such that by the end of the study, everyone's was poor. So at least with the interventions used in Today, we really were not able to move the needle. A useful thing we learned from Today is that if your A1C rises over 6.3%, that was predictive of losing glycemic control at the next visit, or if whatever number it was went up by more than 0.5. So in our clinic now, we use those as cutoffs to add additional therapy. So if someone's A1C is above 6.3 or has risen by more than 0.5, that would be indicative of a need to add another agent. And that is a more aggressive than what we used to do, where we might have waited until the A1C went over 7. What was frustrating is that after initiation of insulin in the Today study, at the time of failure, the average A1C was at 9.7, and a year later, it was nearly identical at 9.5. So despite the fact that we started insulin, their blood sugars didn't get better. And it's not that insulin can't improve your blood sugar, and I showed you earlier from RISE that it can, but it's just that it's such a barrier to these kids to be taking insulin. And so we need better ways for add-on therapy because they're clearly not taking it. So the treatment implications of what I've shown you is that youth are more insulin resistant than adults. Initially, we can get kids into good glycemic control, but 50% of them over time will not have a good sustained response, at least with the older medications, and that metformin and glargine don't seem to preserve beta cell health. And that we also have more insulin secretion, and that this burden in adolescence may be what drives them to more beta cell failure. So we think that we need more aggressive treatment in kids to try to prevent this beta cell loss. So this algorithm is something that is just sort of roughly what we use in clinic, and it's just showing that if you're starting out at any point, if your A1C is going above greater than or equal to 9, that's when we tend to add in insulin. But that if your A1C is less than 6.5, and now with the Today study, we might say even if you are dropping that to 6.3, that you continue your current therapy. But if you go above that is when we start adding in additional agents and kind of working our way through. One thing that was quite interesting from the Today study, if we look now at specific drugs and what data we do have about drugs in kids, is that the thiazolidine-dione rosiglitazone that was used in the Today study, the response we saw was counterintuitive. Usually TZDs are thought to improve insulin sensitivity, and to do so partially, at least, by moving adiposity out of the visceral cavity and into the peripheral, so getting it out of your liver and your viscera and into the hips and thighs. But in today, we found that subcutaneous adiposity did increase in the rosiglitazone group as expected, but so did visceral adiposity. And it did more so than the metformin or the metformin plus lifestyle group, which is the opposite of what would have been hypothesized. And so this also kind of gives us pause and stresses why we need to have separate studies for kids, because the results may not be as expected. The other data that are available about specific medications in kids with type 2 diabetes beyond the metformin and the insulin and the TZDs that I've shown you are sparse, but are coming. There are more studies happening. What we do have is there's when we're talking about the GLP-1 receptor agonist group, which are drugs that increase satiety and increase insulin secretion, but not with the hypoglycemia that you see with insulin. Is that semaglutide has been used in adolescents with obesity. There's not yet a published study with type 2 diabetes, but in adolescents with obesity, they lose weight. So shown here is placebo, where there's no change in weight, and semaglutide has 15% change in BMI, which is impressive and dramatic. Unfortunately, there's no permanent effect. As soon as you withdraw it, there's only 1 point here on the graph, but weight starts to go back up. And what we do have data in kids with type 2 diabetes is from the ELLIPSE study of liraglutide, another GLP-1 receptor agonist. Liraglutide is daily, whereas semaglutide is weekly. And so the preference now is for these weekly meds because they're easier to use. But in the ELLIPSE study, they were randomized to either liraglutide or placebo, and then they were kept on metformin plus or minus insulin, depending on what their control was. And what was seen was similar to the semaglutide study. There was a drop in BMI. And then also there was improvement in hemoglobin A1C, as well as in fasting glucose. So quite encouraging. So these medications are being used off-label in kids in our clinics quite a bit. The problem we now have is access, at least in the United States, due to the cost and insurance coverage. These are quite hard to get. But very encouraging. But we are lacking are outcomes beyond glycemia. So a need is what's happening to kidney function and what's happening to the cardiovascular system and the liver, et cetera, but quite encouraging early on. So I've been talking about glycemia, but I want to make sure that we're also pointing out the fact that type 2 diabetes is surrounded by the metabolic syndrome associated complications: hypertension, fatty liver, kidney disease, sleep apnea, high triglycerides, low HDL, and then also polycystic ovarian syndrome. So it's important that when you're seeing kids with type 2 diabetes that you're screening for all of these complications. So I just have an illustrative case here of a kid who has multiple of these, just to kind of give an example of what our clinic does currently for these. So this child has a BMI of 40. So based on that, we would be offering weight management, of course, lifestyle, trying to address diet and exercise, but also sleep. We see a ton of kids who are staying up super late, getting up late, have disordered sleep, as well as sleep apnea. Depression and disordered eating are also very common in these populations. So in addition to these lifestyle topics, we would be trying to start with weight-sparing type 2 diabetes medications if possible. And in somebody with a BMI in this range, we would also consider bariatric surgery. He has hypertension and a family history of cardiovascular disease. So with a blood pressure of 150/95, we would likely start with an ACE inhibitor. Another consideration is that if you're choosing diabetes medications for him, an SGLT2 inhibitor could be helpful because of the fact that it may also improve blood pressure. He also has elevated liver enzymes, so likely has fatty liver. And so in addition to weight management, other considerations if you're trying to decide which diabetes drug is that pioglitazone does have some evidence of improvement in fatty liver. And then in adult data, GLP-1 receptor analogs are showing large decreases in liver fat. And also some positive effects of SGLT2 inhibitors, but none of that is in kids. So we need pediatric data. He had high triglycerides of 799. So in that case, we would start a fibrate, assuming that glycemic control has already been worked on first. And we usually do that if the triglycerides are over 400 to try to prevent pancreatitis. And for his LDL, after dietary recommendations, might need a statin if he's remaining over 130. This child had microalbuminuria, and in which case then a ACE inhibitor would be first line, but also an SGLT2 inhibitor could be a good choice for diabetes medications because that may help with kidney disease as well. And then as far as his A1C itself, this child was on metformin when I was referred him. We would continue that. We would want to talk about compliance and consider extended release if he was having trouble with GI symptoms or compliance. And then we added in a GLP-1 receptor analog in him, and also a SGLT2 inhibitor. But with the SGLT2, we couldn't do that initially because his A1C was too high. So you need to have caution with high A1Cs and ketone production because of the concern with euglycemic DKA. But this would ultimately probably be a good choice for him because of his blood pressure and kidney findings. Pioglitazone is nice because it's oral, but there is some concern about the weight gain, of course. And then we just don't know from that Today study data if there's concern about the distribution of body fat, but trying to wean, his insulin as quickly as possible, which is likely contributing to weight. So the last slides I just wanted to show to close our bariatric surgery data. What I've shown you is, the metformin, the insulin, and the TZDs are not super impressive in kids. There are some encouraging findings from the GLP-1 receptor analogs, and then there'll be data coming from SGLT2 inhibitor trials in kids as well. But what we do have now are bariatric surgery data. So I collaborate closely with Tom Inge, who ran the Teen Lab study. And the Teen Lab study was bariatric surgery in kids. And what we did was to try to do our best comparison. We compared the kids in Teen Labs who had type 2 diabetes, and they were only 30, to the kids from today who had the closest age and BMI. But I will say that we couldn't get a BMI match perfectly because of the fact that Teen Labs, by definition, they were referred for bariatric surgery, and so they were heavier. But otherwise, they had similar kidney function, A1C, and insulin sensitivity, and racial ethnic distribution. And when we compared these groups, is that the BMI dropped in the Teen Lab study, not surprisingly, with bariatric surgery, and actually got into the same range as the BMI of the Today study. But despite being of similar BMI, the glycemia was much better with bariatric surgery, and we also saw a large improvement in insulin sensitivity, unlike the flat lines that I showed you before with medical treatment. In addition, we saw a reduction in hyperfiltration and a reduction in microalbuminuria rather than worsening, as we saw in the Today study. And then interestingly, when we compared the Teen Lab study, which is kids, to Labs, which is adult bariatric surgery, they had similar weight loss. But despite similar weight loss, more of the kids came off of their type 2 diabetes medications, and none required insulin in the Teen Lab study, whereas there's a small amount of adults in labs that remain insulin requiring. And similarly, hypertension remission was higher in the kids in Teen Labs versus Labs. So despite similar weight loss, the kids seem to respond better to bariatric surgery. And so locally now, our group is looking at VSG, specifically vertical sleeve gastrectomy, because that's the best tolerated form of bariatric surgery. And it's now almost exclusively, at least in the United States, taken over Roux-en-Y. So we're looking at what happens with VSG, because in the Teen Lab study, they were mainly Roux-en-Y. And this is very preliminary data, but we're showing improvements in body weight, body fat, and A1C, insulin sensitivity, and secretion, and remission in need for diabetes medications at 3 months. In addition, when we look at a mixed meal tolerance test, we're seeing similar peak glucose, but much more rapid recovery of blood sugar, more insulin secretion at the peak, but then lower later in the curve. And a markedly higher response in GLP-1 and PYY, the gut incretins, in response to bariatric surgery. So physiologically exciting responses, and we'll be following these kids for longer. But we're also seeing improvements in some of the cardiac abnormalities that I mentioned. So specifically here, improvements in longitudinal strain or systolic function. And we're also seeing reductions in cardiac fat, visceral fat, and hepatic fat. So in conclusion, youth onset type 2 diabetes clearly differs from adults. It appears more aggressive and responds more poorly to the historical medications, although that may be different now with GLP-1 receptor analogs and with SGLT2 inhibitors. But some of that, it remains to be seen because we don't have a lot of data beyond glycemia. So we need more long-term studies of the GLP-1s and to be looking at beta cell function, cardiovascular, hepatic, and renal outcomes. And then we really need a better understanding of what the early changes in puberty are regarding insulin sensitivity and clearance that puts some kids at risk and others not. So we're now part of a large study that's just beginning called the Discovery Study, run by the NIH at 15 sites that I'm helping lead, where we're trying to follow kids with obesity at the beginning of puberty longitudinally who do not have diabetes to try to understand who develops diabetes over time and why, and look at much deeper at things like social determinants of health, mental health, and also we've targeted the American Indian population as well as Hispanic and African Americans. So we've got Navajo and several other tribes in Oklahoma participating. And then finally, we need longer term data on the bariatric surgery. And so we also have a multi-center study that I'm helping run that's looking at vertical sleeve gastrectomy versus medical therapy, but the key being medical therapy that's modern, so that we can, rather than comparing to the Today study where we use metformin and rosiglitazone, we're comparing kids with VSG who are being treated with GLP-1 receptor analogs and SGLT2 inhibitors to try to see how those line up. So I just would like to acknowledge all of my collaborators and funding, and thank you, and we'll stop for questions.
Thank you so much, Kristen. That was wonderful. I'm sure everyone would agree that it's really incredible to see so much of the, I guess, the groundbreaking research, like the seminal studies in this space being presented, but also you gave many clinical examples of how that may have implications for practice. So thank you so very much. And I was also thinking as well, how when you were talking about the Today study, how important, it reminded us of how important it is that physical activity is brought in, or young people are supported with implementing or engaging in physical activity, particularly in light of the challenges at the moment, or the unknowns in terms of what are the best medications or other treatment practices that we may have available at this point, which obviously are improving at a rapid rate as you and your wonderful teams continue to do your great research. So thank you. Does anybody have any questions that they would like to ask? Would you like to come up and ask? Can everybody online hear Matt if he speaks from where he is?
It's an online question anyway, so I'll send text for them. This is from Ken's Diabetes Centre. Can you expand more, Kristen, on your approach to treating lipids and statins in young adults, including the risk of pregnancy?
Mm-hmm. Yeah, thank you. So the question was the use of statin in knowing that we're talking about a young population who would be at risk for pregnancy. So certainly we would want to start with dietary recommendations first, and not treating the very first number that we're seeing, and also trying to improve glycemic control and any other risk factors that we can. But when we're persistently seeing an elevated LDL in this population, I feel like we can't ignore it because of those cardiovascular things that I was showing you. And so, knowing that from the Today study that we were seeing heart attacks and strokes, et cetera, in the mid to late 20s, I feel like waiting until they get to be adults is too late. And so, trying to combine preconceptual counseling to make sure that people are aware of the potential risks, but we're feeling like treating is outweighing the risk of waiting, if that makes sense. So we are using statins in the population where there's persistent LDL elevation, despite trying to do some of those initial first steps. But if it's a triglyceride elevation, I would do a fibrate first. But as I showed you, however, despite the fact that we did really intensive preconceptual counseling in the Today study, we still had high rates of teenage pregnancy. So it's something that is a balance and important to keep discussing.
I've got a question. My name's Tara, I'm a dietitian, and it's about, I think it was Today study, it was a bit earlier in your presentation, around the metformin and lifestyle factors. I was just wondering what the lifestyle intervention aspect was.
Sure. Yeah, so for the Today study, there was a person called a PAL, which stood for the physical activity and lifestyle person. So, but we called them a PAL because they were like the friend of the participant. And so the participants in that group were assigned a PAL. The PAL would go out to the community. So they did some home visits trying to, look at what was the food in the home, what was the situation that the child was living in, to understand what kind of recommendations could be made safely for physical activity. But the downside that you could criticize is that they made recommendations for regular daily physical activity, but they were not all monitored and observed. And so that's why, I was saying that there was actually a sex difference, because it wasn't like they were brought into a unit and exercised in front of somebody. They were periodically the PAL would work out with the participant, but all the sessions were not observed. And so compliance, ended up being whatever the kids were doing. So it was real world. And then we did end up with less compliance than we would have hoped. So it was more intensive from the standpoint of, really actually having someone work one-on-one and go out to the homes than you would do in just a clinic setting, but not in the hospital setting type of a workout.
Thank you. We have a question up the back with Helen.
Hi, Kristen. It's Helen Murphy here, and my work is mainly in pregnancy. So your current patients are my future patients. So I pay attention and really, really enjoyed your kind of deep understanding of pathophysiology. I just want to pick up on Matt's comment around the preconception counselling. And having spent 2 decades working in that space, I can categorically tell you education around preconception counselling is as effective as education around physical activity. It does not work. So what I'd love to see added to your treatment pathways is safe, effective contraception, by which predominantly we mean long-acting reversible, because this patient population are not remembering to take things that require them to remember to do it all the time. We're in the UK having a big push similar to you, but we're really focusing on women's health, having women's health hubs that are based in communities where no one is allowed to utter the word preconception. So I've never met a young person for whom that's meaningful. So we talk about being sexually active, we talk about safe sex, we talk about contraception, not about pregnancy and things that are so far in the future that they're just not meaningful for them. And so what I'd like to see, especially as we start to expand the range of treatments that clearly articulate, they're so badly needed. We've got to be more aggressive with our treatment, but we have to match that with being much more aggressive with our approach to proactive, safe, effective contraception, and just throw this preconception counselling literally out the window.
Yeah, no, thank you so much for that comment, and I can't agree with you more. And when we added the preconceptual counseling aspect to today, it was later on, as we were seeing those pregnancy rates, it was not effective. And what was effective at some sites, and we happened to be one of them, is that we got a grant from our state of Colorado for long-acting contraceptive administration. So the girls in our study who got that for free, that's where we saw the drop off in pregnancy rates. So that I can't agree more. That was the only thing that worked. And in the bariatric surgery population, certainly, we're not forcing anybody to do anything. But we're offering, while they're in the OR, that they can have an IUD or a under the arm, etc., long acting placed. And we have a great relationship with our adolescent medicine and teen moms clinic, where if we're seeing somebody in clinic, that we can convince that we have them walk over, right after the appointment to have that type of thing done. So I can't agree with you more. And another thing that I'm excited about is some of our school-based health clinics in the city where my kids go to school are offering long-acting contraceptive as well in the school clinics. And actually had the experience of my own teenage daughter who was having problems with heavy periods and menstrual cramps. And I could have easily taken her to a doctor and had it, what done, but she came home one day and said, "Hey, look, Mom, what I got at school," and she had a implant put in her arm. So it was very easy for her to access, and, who knows why she really needed it. I don't care. I was just glad she got it. So, those types of easy to access ways I think are just critical.
One follow-up question online. Thanks, Kristen, for your really great individualized approach and pragmatic in terms of lipids. But do you aim for a specific LDL target in this age group or not?
Yeah, so trying to get it below 130 is what our clinic is typically doing. And I just wish that, it's a huge gap in research, that we need really in a young population need to know what the target actually should be. So we're really kind of guessing based on adult data. And this is a different population with a different rate of progression. So, I mean, that's what we're doing, but we need an evidence base.
Thanks, Kristen. Kristen Connors. Your presentation was incredibly interesting, but also very disturbing. The rapid progression, I mean, we have seen that previously in the literature, but some of the data you were showing us was even more frightening, really, and that rapid onset of complications. I mean, obviously growth hormones occurring during adolescence is part of that story, but what else do you think is leading to this extraordinary rapid onset of complications, and can we actually help these young people to stop that?
Yeah, so I mean, that's the kind of $1 million question, I think. And so there's a few things I think that we have ideas, some of it is the extreme sedentary behavior of this population, and the high degree of obesity itself, of course. But when we look at physical activity across the lifespan, adolescent girls in particular, really just stick out as being so low. And I think part of the problem is that, it was easier when you could just say, "Hey, I live in a home where we don't have a TV." That would still be rare, but you could do that. But now kids just take their physical inactivity with them everywhere they go, because the handheld devices, is something that you can be inactive everywhere you go. So I think some of it is going to need societal change to address that. I think another aspect is that we're probably picking out the kids with genetically the worst beta cell function. And so some of that is, racial, ethnic risk, because we see kids, with similar BMIs that don't have anything happening. So it's not just the lifestyle. But I think compliance is another question, because in these studies where we're showing that kids respond more poorly to adults, what we're missing is I can't show you, for example, metformin levels. So is it that these medications work less well in kids? Maybe, or maybe it's that they don't take them. And that maybe that's why bariatric surgery seems to be working dramatically in them, because it's something that's done to them where they're, not having to take a medication every day. And so I think, having these weekly GLP-1s where it might be easier for a parent to get one shot in on a kid per week, so things where we can try to take out the fact that having diabetes is so hard, and having to take medications and do things that's different from your friends, is going to be really important too, to make it easier for these adolescents. But the most important thing is just going back to the beginning of, how did we ever get here to begin with, and trying to figure out how to prevent, this is where the talk you're going to get next about pregnancy, the early origins of this, and what happens with counseling in early childhood, visits so that we don't develop the obesity and that sort of thing early on. But it's really this, and at least in the United States, it's, it's the low income, high risk families. So societal change is going to be needed to help make sure that we can address what is needed by these underserved populations.
Thanks very much, Kristen. I think that really reiterates or highlights the power of Janisha's story, who we saw prior to your talk. So thank you on behalf of everybody. That was a really powerful presentation. And I'd love to now welcome the Youth Type 2 Diabetes panel, which is being chaired by Dr. Angela Titmuss. So I will just... So many of you would know Dr. Angela Titmuss, who's an early career researcher with us in the Diabetes Across the Lifecourse Partnership, as well as the only paediatric endocrinologist in the Northern Territory. So Angela's got a very big job. She's a senior research fellow with us, and her work has a strong translational focus, which has resulted in many changes in practice and policy to improve management of youth type 2 diabetes across Australia. So this is not limited to the NT. Her work is definitely being used across Australia. Her work has also explored the intergenerational diabetes and how exposure to hypoglycemia in utero may affect the growth, cardiometabolic profile and development of offspring. Thanks, Angela. I'll pass over to you and your fantastic panel.
So before we actually have the panel, we have Edwina and Tash. And Edwina Murphy is a young person from Katherine, who's actually working now for Menzies on our Doing It Together project as a peer educator and peer facilitator. It's a big thing for her to present here today. And so really thank her for doing that. And Tash is going to interview her. Edwina actually has already had a powerful voice nationally. She presented at the parliamentary inquiry at the hearing, and she's also been on ABC television telling her story about her diabetes. So thank you, Edwina and Tash.
Good morning, Edwina, and thank you for coming and sharing your story today. Can you start by telling us a bit about when you were diagnosed with type 2 diabetes?
So I found out that I had type 2 diabetes at the age of 12 and 14, I think. We had local clinic coming in the schools to do regular checkup every 2 months a year. They did checkups to every Aboriginal Torres Strait Islander and non-Indigenous kids. At that time, I felt confused and confused about what diabetes was. So after finding out about diabetes, I kept it to myself, didn't make much friends, and yeah.
Can you tell us a bit about your family and other people in your family who have diabetes?
So my mom's side of the family has type 2 diabetes history. It all started from my mom's dad, then it passed down to my mom's older sister herself and her 2 younger brother. And so on, it went down to my siblings and I, my 3rd other sister, myself, and my 2 younger brother. So about mom's story, she lost her eyesight, so on 2 of her toes, and few years after that, she went on dialysis, and she went on dialysis for 5 years, and got a good news that she had a new kidney transplant. which is a good thing. Yeah, came up and down and stayed for another 4 or 5 years. Yeah, but mom's story is kind of incredible. Yeah.
I've heard you talk before about your mum being the main person in your life who's probably taught you about diabetes. Can you tell us how she taught you about diabetes?
Well,
did she used to talk you through what was going on with her, different things? That's okay. Well, good. I know you've told me lots of times that your mum's taught you a lot about diabetes and her story and just shared what's going on with her. Who else has been a good support for you with diabetes?
my mom's dad, younger brother, another grandfather, both of my younger uncles, and yeah, my siblings.
What's been hard about living with diabetes for you?
Well, it's taking medications and insulin to get my brain and muscle working, and getting sick and ending up in hospital having needles.
And what worries you about having diabetes?
Maybe somewhere around the future, my loss eyesight or yeah, kidney failures, many things.
And what helps you manage your diabetes?
Taking my medications, trying to eat and drink healthy, have regular checkups, and yeah, talking more about diabetes in the family.
And you currently have a role at Menzies working with young people with type 2 diabetes. Can you tell me a bit more about that?
Well, I am a peer facilitator for Menzies. I work with young people at Worley and Catherine West communities. We share our stories about what diabetes is, about sugars in food and drinks. Yeah, at Worley, yeah, we talk about a good life with diabetes. Yeah, and I also start studying about being a health worker at Bachelor.
What are you looking forward to in life?
Well, I just want to improve my HbA1c, maybe for a month. Want to become a Aboriginal health worker or a diabetes educator, travel and have adventures.
Thank you.
Thank you so much, Edwina. And Edwina, part of her role is her and the other young people that are peer facilitators really support other young people and make them think that it's possible to have a good life with diabetes, and it's a really powerful role, and it requires a lot of vulnerability as well and bravery, and we thank you for that. And now I'd like to, if the panel members could come down and I'll just introduce you. while you're coming down. So we're having a panel with a few hypothetical cases. I'm just putting out there, these are not real cases. I just kind of pulled together what would be representative cases for discussion. And we have a multidisciplinary panel, Sumaria, as well. So Dr. Michelle Scerri, who's the closest to me here, is the general practitioner and lead of the child health program at Worley-Worlington Health Service. Next that you can see is Teresa Hyatt, who's a remote diabetes educator in top end area of NT Health, and Sumaria Coprus, who's had a variety of roles over the years, but is Aboriginal health practitioner and diabetes educator at Royal Darwin Hospital currently. And then I'll also join the panel. And we've just got a few cases. Yeah. I know you can't really see that from else. So I'll just go through the case, the first case, and then we've got some questions for the panel. And yeah, these are just kind of characteristic or representative cases. It's a 7-year-old boy that was incidentally diagnosed with type 2 diabetes after he was having screening with HbA1c at point of care because he was had obesity. And so his Z score for his body mass index put him obesity range at 3.2. He had a high waist to height ratio, which we kind of use to say that there's more adiposity in the central area of his body. He had acanthosis nigricans, that dark or thickening of the skin over the neck and the axillae. And he had a high HbA1c or diagnostic of diabetes at 8.9%. And the next slide, it's a very classical family history, similar to what Edwina's kind of almost shared. His mother had type 2 diabetes when she was pregnant with him. His father also has type 2 diabetes, lots of aunts and uncles with diabetes, and also older siblings that had diabetes, and they developed that when in adolescence. And his mum was in preparation to start dialysis. And the next slide, also quite classical, some of the social complexities that may be contributing. So he's in a remote community, it's 400 kilometres from Darwin, so there's issues in terms of how to provide that healthcare. He's only 7, but he has a very irregular school attendance, been attending about 50% of the time. His family also move quite a lot between different communities, so there's issues of how we're going to provide healthcare in that context. Lots of food insecurity and a very significant trauma history in the family. And he does have some points that may be points of intervention. He has rheumatic heart disease and has, despite that mobility and all those other issues, has excellent adherence with his regular LA bicillin. And just going on to his examination. So as I said, he has obesity, he has central adiposity, has that acanthosis, which is in the picture. His blood pressure at 7 is borderline for his age, and has kind of a bit of a snoring history and very large tonsils when you examine him. And just some of his lab results. So he's only, remembering he's only 7, but already concerning features looking at his lipids. So having that low HDL and the high LDL, and also concerning or suggestive of possible fatty liver already on at 7 years of age. And at his urine albumin-creatinine ratio suggesting proteinuria, mild proteinuria. So kind of giving that context, which is a very similar case to what many of us would see of young people with diabetes, I've firstly might ask Michelle, what would be your priorities of care, this young person who doesn't know they've got diabetes and they're kind of just incidentally diagnosed?
Thank you. So, I mean, I think, you know, the clinical mind obviously goes to glycemic control is your number one thing that you're thinking about. And then in the background, thinking about, you know, the dyslipidemia, the blood pressure, the obstructive sleep apnea. So I think there's a whole range of clinical priorities straight up. But I think the more that I've been working with people like this, I think the first priority is how are we even going to start? What that first step on a process that's going to be lifelong in terms of engagement? What is that first step, and how are we going to actually approach the first step before we even start to think about how we're going to achieve glycemic control? So I think for me now the main thing is again, engagement. How are we going to engage this person in healthcare?
Sumaria, did you want to comment on that?
Yeah. The first thing is building that rapport. You know, that it's a two-way, and delivering information in a two-way setting. So, you know, give them small snippets to think about. You know, how much cool drink do you drink? And, you know, do you get hyperactive when you drink cool drinks? You know, what happens when you drink water? Do you feel good? You know, these sort of things. And eating healthier food, how do you feel? I promote a lot of bush tucker, hunting and gathering. And I say, if you go down the river, go fishing, and you cook it up and you eat it, how do you feel? Compared to chicken and chips. And the kids will say, yes, I feel good. So I think little bits of snippets to change. And I think that trust, you know, it takes time for change. You know, we don't like changing anything. So I think it's important having small snippets to make a change in their life. That's how I look at it.
Thanks, Mara. And Teresa.
I agree with what both the others said. The only thing I would add is, particularly if this is in a remote community and they're moving around a lot, is probably trying to establish who is his most important support people, who's going to be his ongoing support people. Perhaps in each of the clinics, somebody he feels and trusts in each area, if possible, like an actual clinician who he can have a longer term relationship with to get these snippets of information from, because obviously he's moving around a lot and that's difficult. So, but the really positive thing is you want to really try and work on those positive things that he and his family are achieving, like the fact he is regularly managing to get his LA bicillin. What is making that possible, and how can we try and work on that positive to help with his diabetes care now? Once we think about those social kind of things, then we might be able to look at the clinical things.
Thanks, Teresa. Sumaria, I was wondering if you could comment on what you think the priorities of care might be for that young boy or his family, what they might be thinking in that moment and what they're prioritising.
Well, we brought this young fella into Darwin for stabilisation and education, and spent a lot of time with him and did all that. And I think the important thing is he understands he's not the only one. The kids think they're isolated, you know, and that's the biggest problem. I'm the only one with diabetes. And as I say to him, you know, we've got other kids with diabetes. You know, we've got younger kids than you with diabetes. And we need to tell them that it's manageable. Or, you know, they're not going to get sick if they take their medicines. And with this young fellow, I was very impressed. When he went for his monthly injection, they did a random blood sugar and there was 9.4. And we've never seen 9.4. And that was in the community setting. So things have changed. I think intense, you know, bring them in for a couple of weeks, educate, support, and then follow up at the community setting, where I check on them, just having a look at their notes, seeing what's happening. And if they're coming in for regular checkups, that's great. If they're not, I text their parents and I say, what's happening? They haven't been to the clinic. They're not taking their tablets or their insulin. What's happening? And then the parents will ring me or text me back. I'll take them this afternoon. So it's just that continuous care. And I think that's really important. And they don't think I'm a humbug. They just think I'm their friend. So, yeah, that's all it is.
It's, so this case is a mix of about 3 or 4 different people, so it's not one person that you're thinking of. Teresa, I wanted to go back to you because you talked about the importance someone's moving around different communities, working out who's going to be their support person. Who do you think should be involved in their care?
Quite a wide range of people. Hopefully there'll be a diabetes educator like myself, and hopefully I'd see them regularly. Hopefully there'll be a nutritionist, AHP, particularly important if there is any in those communities. Not all communities are lucky enough, or a community support person. In this young boy's case, I'd say it's probably also obviously his family, his parents, his aunts and uncles and other family members who have diabetes. Like Edwina said, they were really important support people to her. And obviously he's already got other chronic health conditions, so he probably already has a relationship with the people caring for those. And obviously we'd like to try and re-engage him with the school system somehow, whether that's the remote school or elsewhere. I know obviously people really love to be at home. However, I know a family whose daughter was really not engaging with school at home, and they've decided to send her to boarding school, even though she's at primary school level, and she's really doing fantastically there. So I'm not saying that's a solution for everybody, it certainly isn't, but it is something else to consider. So re-engaging with the school, social support systems, perhaps social emotional well-being staff, if there are people, like as many people as you can think of, that. But it's about finding probably the right person, and that may take you trying a lot of different people to find the person that's the best person for this boy.
Michelle, my question's for you. You talked about at the very beginning, like just stopping and thinking, like, where do we even begin? Or like, where's the point of engagement? And this young person's not engaged in school. How would you approach that and think about how that might affect diabetes, or how that might help his diabetes?
Yes, so probably on a couple of different levels. I mean, some of the, we've had a lot of success where we've been able to engage schools where children are attending to help support their diabetes education. So I think there's a double benefit of having kids back in school where they're not only learning and improving literacy, which is going to help lifelong with their diabetes management, but also that it provides this sort of scaffolding that may or may not, you know, in a household like this person's, where there's just so much chronic disease and lots of other social factors. School might be the scaffold that he needs for routine, for maybe instigating medication and monitoring the medication, keeping things safe even. So I think there's a lot of benefit in doing so. I guess we've also seen quite a few children, I guess just because of the same risk factors, who also have neurodevelopmental concerns, which are going to impact lifelong on their ability to manage their diabetes well. So being back in the school system will allow assessment supports, things to be put in place, and really without school, you can't really achieve that. So I think there's lots of reasons to do so, the social and academic and the assessment type reasons.
And how would you go about working with the school?
So as Edwina said, we've got a really, really long history of working with schools. We in Katherine, so we have always run a school screening program for at least the last 15 years or so. And I guess just as an aside to that, that means not only do we have a bit of a relationship with the schools to begin with, but it usually means that we've also got a bit of a relationship with the young people who usually know us. So I think we're looking at this sort of a moment in time when we're about to give some really bad news to a kid that's big for the child as well as the family. But I think having a relationship with the school and with the kids going to the school, predating that really difficult diagnosis, is probably one of the most beneficial things that we have at our disposal. So, I think Edwina's story was a really good one, that even though so she was diagnosed during a school screening visit, and even though it was really confusing for her, it was the same people seeing her, talking to mum, probably the same people that have looked after mum during a pregnancy, and it's the same people over and over again. And I think, I know that's not always possible. I know it's one of the biggest problems that we have in particularly remote settings is workforce retention. But I think there's always going to be some people. And I think, as Teresa mentioned, I think if this child's coming in to have his rheumatic heart needle, there's someone he knows in that clinic. And even if that particular person is not the person who knows how to explain the diagnosis or what's going on. That person is so critical because they know the family and they understand that aspect of that person's life. And I think that's really important. I hope I answered the initial question.
Thank you. Sumaria, the question's for you. So he's 7, so thinking about his initial management, talking about metformin or insulin, how would you go about talking about that, and what do you think would be the barriers for the family in trying to do that, or what their fears may be?
Well, depends on their home life, and it's a routine sort of thing. So sometimes if they're going to school, we'll talk to the school and say, can he have his tablets at school? You know, if he's not taking them, you know, so it's better to have 5 days a week than none a week. Or just educate the parents how important it is, and simplify terminology as well. You know, we get all clinical and say, we need to get this HbA1c down. You know, he needs to take his tablets and insulin. But what would you say is how much sugar in his body, and the tablets will help. And I use a drawing of the body and show them how the mechanism works at a cellular level, the parents. And then we talk about try and eat healthier, more stews, instead of more veggies in the stew instead of billabong stews. And you know, you got your 5 veggies there in one stew. So yeah, it's simple. You can't expect them to go out and buy fresh veggies and fruit and stuff like that when they're in remote. So tin or fresh if they can, but just simplify things. You know, frozen veggies have got the same value as fresh, and it's cheaper in the communities. So you just look at their environment and see what they can do in their little household. And that's all you can do. And encourage water, and, you know, show them the difference between sugar overload and diet. And with cool drinks, it's a special occasion. So it's not a daily thing. So, and explaining that to the parents, and how water cleans out their system and gives them that energy. So, yeah.
One more question for you, Teresa, for the next case. When you're working with a family where there may be a really strong history of diabetes, and so mum, dad may have diabetes, but they may have struggled with their own diabetes, or that diabetes story hasn't really resonated with them, how do you approach or try to change the trajectory of the young person when there's this whole other history in the background?
I guess the main thing is, particularly when you're first getting to know the child, is really to emphasize that the story they've seen in their family and their extended family doesn't need to be their story, that they can be healthy and well, that there is hope for being healthy with diabetes, and that perhaps, and try and get a whole of family approach towards the managing diabetes. Like if mum and dad are still, if they're all in the same family still and they're all at home, perhaps they can be the starter to try and change things. It's very difficult though, because obviously if this is a young child like this child, he's got no control over the shopping and the groceries and who buys what, and little to no options over it. And trying, just as Sumaria said, cut down the sugar and things. But also, I can't remember, was this the family that you said didn't have a fridge?
In this case, yeah, no.
So he's got no fridge. So, okay, well, we said we're going to start him on insulin. We want him to do insulin injections. Well, how's he going to do insulin when he's got nowhere to store it safely? So we may need to help the family negotiate with the local council or the regional shire. Some of the shires will give loans or extensions to help you buy fridges and washing machines and things, because without those structural things in place to start with, it's very difficult. But I think it's the main thing is that importance, that what's happened to your family doesn't have to be your story for a young child, and being healthy. But yeah, it's very difficult, to be honest. When I first read these case studies, when you gave them to me, it made me just feel very sad, because it's a summary of what we see all the time, but it is a very sad picture.
Because there's also hope when we saw like Janisha's
yes.
story as well, and Edwina and other young people. I'll go on to the next case. Thanks, AG. So this is a 13-year-old girl, was again diagnosed just on screening, on routine screening in light of family history, and HbA1c was 10.2%. So did not know they had diabetes before this. It has quite a complex medical background. So this young person only has one kidney, and on screening at that diagnosis point had dyslipidemia for low HDL. Wanted to point out, so this young person does not have obesity, had a BMI of 22, and waist to height ratio was just slightly elevated. So they had a kind of normal BMI, but their waist to height was slightly elevated with central adiposity. And at diagnosis already had marked proteinuria, probably related to their underlying kidney issues. So obviously this is a quite different story to the first case. They also have a strong family history. Their mother has type 2 diabetes, had GDM in the pregnancy, but now has type 2. Type 2 diabetes affects grandparents as well, and also a younger sister who was diagnosed at a young age. And again, there's quite significant social complexities, and living in a town, there's very little extended family support to kind of support this family unit. And the mother has lots of issues herself of her own health, but she's also carer responsibilities for a grandmother. Food insecurity, there's a history of trauma, domestic violence, no fridge, and very little school attendance for several years. She's 13, but not really been at school since she was 9. And there's also mental health challenges in the family and concerns about this young person. And this young person herself really takes on a carer role for her siblings, so has other things, other priorities for her. So I have questions for the panel again with this case. So there's some similar challenges, but there's also some quite unique challenges for this young person. And I'll start with you, Michelle, again. If you, what would be your priorities of care at that moment when you've that first diagnosis, but also thinking 3-6 months down the track, what would you be starting to prioritise?
Yeah, so I think, I mean, there's obviously a higher level of glycemia, which is going to make us more nervous and want to address that really quickly, and particularly with one kidney and already proteinuria. So I guess there's a sense of urgency to try and get started on some probably metformin and insulin to begin with. So yeah, I think that is the health priority. But I still think that underlying all of that is, you know, about building capacity to manage, to understand what lifestyle changes are going to be helpful, are possible in this situation, about learning about how to manage medication, where's it going to be stored, how's it going to be taken, how are we going to remember to take it, how are we going to keep it safe. Yeah, and as before, I think, you know, re-engagement with school is a priority for all of those reasons, for scaffolding, social supports, and lifetime, you know, learning for lifetime.
And Sumaria, my question is for you. With this young person who's obviously, we're really worried about her renal function and her future risk, how would you approach those discussions with the family and with her about her kidneys?
I'll explain how the kidneys work and how it gets rid of waste. And what I say, everything you put in your mouth gives you energy. If you're putting rubbish in your mouth, you're not going to have that energy, obviously. So yeah, and I'll just draw a picture and how the kidneys work and how the waste happens, and just say you need to start cutting down, because with a kid you can't say no. and just putting these small ideas, and every time you see them, you just continue on that track. And the importance of taking her medications, the importance of wearing shoes, and in this case, I think they need outside support, where, you know, like wraparound support because of the age, and trying to access a fridge. And yeah, and in this case, when we seen her in Catherine, I just, you know, they're already getting neuropathy, and they're saying they've got pains in their feet. And I just said, next time you go shopping, ask your mum to buy you some shoes. So one of them came in with shoes and socks, and the other one came in bare feet. And I said, where's your shoes? And she goes, I left them at home. But, you know, like just encouraging them to do small changes, you know, and cut down on cool drinks and more stews.
For you, Teresa, I suppose what advice would you give to the local clinic, they're providing the ongoing care, about things we could do to help protect her kidneys or protect her health?
Regarding the kidneys and the results we've got here, I don't know if that's just a one-off thing or if it's been a pattern. If it's just a one-off, the ACR is up, but we'll also be starting to think about just check whether she's got just an infection or something that's caused it. Is she sexually active? Is it a sexual infection or a UTI? I know she's only a young girl, but we do see a lot of young women are already active, and that'd be one thing I'd want to think about too. We'd want to check and see. We want to do routine, regular checking of her ACR rather than just once. We try and engage her in more water and things, as Samara said, and family history and discussions about, you know, what the kidney is and how it works. I forgot what the question was.
Just general advice that you give to protect her renal health that you give to the local clinic.
So yeah, healthy diet, healthy food and drinks, avoiding salt and too much excessive salt and things. That'd be what you'd try and maintain health, yeah. And infections and skin infections and scabies, all of those things can contribute to renal injury.
Thanks, Teresa. It's a question for you, Michelle, about thinking, you talked already about what you choose initially. You'd be thinking like metformin and insulin but what would you be thinking would be medication choices down the track compared to the 7-year-old boy in the first case? What would be the differences?
I feel like you're trying to trick me. Yeah, I mean, down the track, she might be a candidate for an SGLT2 inhibitor. She might, and I guess we're also thinking about an ACE inhibitor. And I think your point's really good, Teresa, about like we need to sort of see what the long-term history is of this. Is it more acute or is it longer term? And tied in with that, thinking about contraception as well. Yeah, did I cover that? So yes, potentially an ACE inhibitor, along with some contraception and maybe an SGLT2.
Compared to, he was only 7, the younger boy, but if a little bit older or thinking down the track, what would be your other agents that you might be thinking of for him?
And maybe a GLP-1 agonist, which I think, which is something we're using quite a lot and finding to be, was really interesting, that first talk actually, but finding to be practically one of the most easy, most accessible medications and probably one that we're seeing the most practical outcomes for really in practice. I was going to mention, sorry, no, go on, Tree.
No, I had a question about that in the previous talks I didn't ask too, and but you can probably answer. It's like, what age group are we using GLP-1s and SGLT2 is in now?
Yes, so answer, it's off-label in Australia, and so we are using, but as Kristen mentioned, we don't have the long-term data, but it's a balance of risk in terms of thinking about we know what the outcomes of chronic hyperglycemia is, so trying to balance that with, it needs a really clear consent or discussion of family that I can't guarantee long-term safety. I don't have that data, particularly in pre-pubertal children. So we're using it very commonly in pubertal children with discussion, but also really clearly thinking about whether they're the right person and the phenotype of that young person. So I agree with Michelle that this young person has a normal BMI and kind of marked proteinuria. I'd be really leaning towards an SGLT2, and a GLP-1 may not be actually maybe harmful in some. And I've seen young people who are underweight with type 2 diabetes lose further weight on an on a GLP-1, and that is not what we're wanting. So really, it's an individualized approach. It's used very uncommonly around the world in pre-pubertal children because none of the studies have included really under 10-year-olds. But saying that, we have done that in some young people. So it's just, yeah, balancing the risk. And it was just one last question that was for you, Teresa. It was about an SGLT2. Just wondering if you could just finish by talking about how you would keep people safe while they're using an SGLT2 and what discussion you have about that.
Okay, we are using SGLT2s very widely in the communities I visit. So the talk is always involved about all the risk factors involved in it and how so I usually start off with talking about how the medication works. I use a little description of it as it flows in, because that's the name of the tablet. So it flows in and it flows out. You have to drink plenty of water to flow in so that the sugar can flow out when with your progeny, when you pee. So that's how I usually describe it, as a flows in, flows out tablet, and the importance of taking it every day. But not if you're not eating. So don't take it if you're not eating. Don't take it when you're unwell. Those are basically the descriptions. And I talk about the risks of genitourinary infections. And if you do have any kind of infection, to come straight back to the clinic so that we can treat it promptly, and then hopefully it'll go away. But if it does recur, we will have to stop the medication. But mainly the messages are drinking plenty of water, and don't take it if you're not well or not eating and drinking. So if you have no food that week, if there's some food insecurity issues and you're not eating, then just have to miss taking it, really. We look at what the tablet looks like, so they know which one is which. Yeah, that's, I think, but that's it really, is not taking it if you're not. And if you do feel unwell, if you have abdominal pain or nausea and that, please come to the clinic and that get checked so we can make sure if your ketones are okay. And so I usually talk about, that's basically what we talk about.
Thank you. I'm going to take that flows in, flows out. I like that. Just to finish, before I say thank you to our panelists and Edwina, just a reminder that there's over 30 videos on our website. They include lived experience videos of young people and Aboriginal health practitioners from across Northern Australia, as well as there's also some animated videos with explaining diabetes that are kind of like analogies of how to understand diabetes. And there's also some other videos which talk about different aspects of diabetes and medications. So, and the music video Diabetes is up there as well. So please take a chance. But just wanted, if everyone could join me in thanking Edwina, if you come down as well, and Sumaria, Teresa and Michelle for their time today.
And I would just like to welcome everybody to a half-an-hour break. We have morning tea here in the foyer, and those in Alice Springs and Cairns also have morning tea provided. We look forward to seeing you back here at 11:15. Please don't be late.